for colorectal cancer, I would like to call the chairperson on the stage, Dr. Suddhasattwa, Alok Banerjee, and Dr. Anadi Acharya.
It appears that the other two chairpersons are somehow stuck up somewhere else. We'll start the session with Dr. Sudhir O V's topic, the role of TaTME, is it a game changer?
Good morning, everyone. My topic of my presentation is the role of TaTME. Is it a game changer? So we know that the laparoscopic TME has been well established, but there are some challenges to face in laparoscopic TME, especially in obese patients, in male patients, in antroid and narrow pelvis, where the positive, there could be a positive CRM margin and a distal resection margin. There could be a lot of conversion rate is more in them, and the low TME quality might probably increase the local recurrences. And also, a bulky mid-rectal tumor may hamper the distal dissection and narrow male pelvis, making the TME difficult. So the transcendental TME is done so that the TME can be done from top down and from bottom up, so that a complete mesorectal excision is achieved in such patients. So this is probably the reason why by R.J. Hield in his comment said that it could be a new solution for some old problem, the transcendental TME. Now, transcendental TME could be pure transcendental TME where the whole dissection is done transanally. The TME, the rectal dissection, the vascular ligations, the sigmoid and descending colon splenic pressure mobilization is done, and a coloanal anastomosis is done. So that's pure TaTME is very rarely done, and there is some hybrid TaTME which is mainly referred as the generally as TaTME, where a combined approach, the abdominal part is done initially, TME, and then the lower part of the TME is done transanally. It could be of two-team approach, the abdominal and perineal, both surgeons, one surgeon operating on the abdominally and the other team operating perineally. But it needs two cars more of operative setup, or a single team approach where you open the laparoscopically, the same surgeon operates on both sides. In two-team approach, it might mean if there's a difficulty, they can help each other and could save time also. So there is a complete exposure of TME plane and can be achieved, and precise dissection can be carried out. And the anastomosis could be either a coloanal anastomosis or double bursting staple anastomosis, which is transanally done. This is a case of transanal TME that we have done recently. We have done only very few of them. This is the obese male patient, 55-year-old, a tumor at 5 centimeters from the anal verge. So you can see that bulky mesorectum, and you can see the difficulty which we are facing to go low in the pelvis. So that is the anterior mesorectum trying to be. So the visibility is very poor in such a narrow obese male antroid pelvis. So now we have moved to perineum, that is the TEO apparatus that we have kept in the anal. And you can see that's tumor you can see, and it's just above 5 centimeters from the anal verge, so just above the anorectal junction, which is being marked by cautery. And now a bursting suture is done to close the lower anal canal. This is to prevent the tumor spillage down. This is a very important step, the bursting suture of the lower part of the tumor, so that the tumor spillage and recurrence can be prevented. So here the thing is that we see where we are dividing. The distal margin is so very clearly marked initially itself. So the rectum is divided perpendicularly to get into the mesorectal area. Now you can see the lucidal tissue on the right side. And the same thing is done on the left side. So the lateral, this is done first because these are known as the sweet spots. Because posteriorly there is the sacrococcygeal raphe, which needs to be divided. Anteriorly, now you can see the prostate. So transiently we are going, actually the abdominal dissection we have seen that has been already done. So it's a single team approach that we were doing, but my colleague has joined me at this point of time. So there's a prostate anteriorly you can see. So we have to be very careful in this dissection so that shouldn't avoid the violation of the TME plane, and even some unheard complications like urethral injury had been happened if the dissection plane is strong. So now that's the posterior dissection. Go precisely in this is that the TEO that platform helps you a lot in this dissection. Now we have met the abdominal dissection plane, and that is divided, and now the tumor is brought down transanally. Transanally, the tumor is brought down, and now that's the sigmoid colon, which is divided, and that's the specimen, and a transanal coloanal anastomosis has been done with an ileostomy. So this type of surgery needs some of the specific platform, like either a TEM scope, which uses binocular vision, or stores the TEO scope, which has that a camera could be attached to that, and either a gel port also. Now, which are cases for TaTME? Maybe according to Rouillet's classification, a tumor above the supraanal, the anorectal junction above it, can be divided at the anorectal junction, but if it's juxtaanal, that's very close to the within 1 centimeter of the anorectal junction, might need a partial internal sphincter removal, and if it is lower than that, then it may need a total internal sphincter excision. But if it is infiltrating on the external sphincter, you may need an APR. Now, when you compare the laparoscopic TME and TaTME, there is conversion rate in laparoscopic TME is more. The TaTME registry publication with a lot of patients, like 76 and 1,544 patients, has shown that the conversion rate is very low, is 4 to 6% in TaTME. And the Canadian expert group has is up to 4.2%. Dutch colorectal data shows the conversion is only 1.5% in TaTME. And the previous, most of the control trials has shown that in laparoscopic TME is high, is 9 to 16%. Even roller trial, the robotic trial had shown a conversion rate of 8.1%. So the better plane of dissection transanally might reduce the conversion rate. The TME specimen quality, because of the better visualization of the TME planes, the composite marker of TME, the distal resection margin and circumferential resection margin, is in TaTME is up to 91% with a circumferential resection margin of 4% positivity, and distal resection margin 1% positivity. That's in the Dutch TaTME study. Whereas the laparoscopic, the controlled studies, the randomized studies which previously published, the laparoscopic, the composite marker is 82 and up to 89% in open. Now, why this TME clearance is mainly because when you transanally, when you go, you can see that the line of dissection, excision is like that, is beyond the pelvic aponeurosis. Whereas in TME, the abdominal TME or laparoscopic TME is in the TME plane. So you might get a more clearance in TaTME. Now the local recurrence of the 5-year local recurrence of the TaTME. This is the first randomized trial, 100 patients, 6 centimeter from the anal walls, and has shown that the CRM positivity is 18% in in open surgery and 4% in TaTME. And they have published their 5-year data also, which shows that the local recurrence is 3% versus 5% without much statistical significance. This is another study which shows the 3-year outcome after transanal versus laparoscopic TaTME or rectal excision for cancer within 12 centimeter from the anal verge, 344 patients TaTME and 366 in lap TME, and has shown that cumulative local recurrence is 3.6% in TaTME and 9.6% in lap TaTME. This is the subgroup analysis, survival and recurrence, which favors the TaTME. Now, the local recurrence in many other studies which have shown that it's up to 2% to 4%, the local recurrence in many other studies of TaTME. The sexual and urinary function following laparoscopic surgery. The Prakash has published from Cochin that the moderate to severe bladder dysfunction for a mean age of 58 years is up to 2.4% at 9 months, and sexual dysfunction is up to 55% at 9 months. So the bladder and sexual dysfunction was more in low rectal tumors, whereas if you take TaTME, it has shown that, it is again a randomized study which shows that 38 TaTME and 34 in lap TME, and has shown that sexual activity and the erectile function is better in TaTME. But there are problems also. The Norwegian data is not so encouraging. It's shown that there are a lot of local recurrences. In 110 of their initial patients, they have found that the local recurrence had been 10 local recurrence, that's 9.5% in 11 months. And so rapid onset of multifocal recurrences in pelvic side walls. So the national, their national average incidence was only 3%, but the TaTME introduction is up to 9.5%. So the health authorities has declared a temporary moratorium for TaTME till further audit is complete. Now, the acceptance of TaTME is not widely adopted, especially in Asian countries, probably because our body habitus is different from the Westerners, and there is a long learning curve. Widespread adaptation for the technique may be difficult. There are incidents of unheard complications like urethral injury. So should be carefully introduced, and that too in high volume centers, and there should be a dedicated training program using human cadaver and proctoring. So these are the ongoing TME trials. There are so many TME trials, TaTME trials going on. Color is there, and the Greca trial. There are so many other TaTME randomized control trials are now going on. So transanal TME has a role in challenging group of patients, which leads to less conversion and good specimen quality, with better visualization of autonomic nerve function that leads to better genitourinary function. It is indicated in obese narrow pelvic males with bulky low tumor, and should be carefully introduced in high volume centers initially. Low-term results beyond the learning curve are awaited. And TaTME is not meant to replace, but rather complement the laparoscopic approach of TME in certain high-risk patients. Thank you.
If there is any question from the floor.
Beautiful presentation, sir. 2 questions. We found the colon is beautifully mobilized lower down. So what is the proximal mobilization of the colon? Second thing is, in a post-radiation case, will you find it difficult when you do a TaTME, will you do an ileostomy?
The proximal extent, that's actually not defined, but usually in obese patient is up to just 1 centimeter from the sacral promontory you can dissect, usually. And for a radiated pelvis, there is certain contraindication, like if this is a prostate cancer radiation, it probably may be a relative contraindication for TME. You might lose the plane, and or previous prostatic surgery, a large prostate and all. But otherwise, the neoadjuvant chemoradiotherapy is not a contraindication. This patient also received neoadjuvant chemoradiotherapy, and if you stick onto the planes you probably might do it without much complications.
Any more questions? No, it seems we don't have any questions. So I have a question, or rather a comment. So from what you have presented, I think the difficult areas in laparoscopic resection, when the pelvis is narrow, the tumor is bulky, particularly in female patient, and of course the patient is obese. This is a good approach. This is an elegant approach. Yeah. But like any other surgery, this also needs to have a learning curve.
Yes.
And for our country at least, more control trials should be done before establishing its value in oncologically, I mean, in survival, local recurrence, sphincter function maintenance, etc. Thank you.
Thank you.